So hi guys, today we are going to see 10 questions. So basically the first question is what is the procedure depicted here? So the answer is Thiersch wiring. Since you can see the wiring being placed over the rectal mucosa, which is nothing but a bursting suture. So there are basically two approaches, perineal approach and abdominal approach. In case of perineal approach, it is easy. High recurrence rate is present because it is not stable enough. Also, it is preferred for elderly with comorbs. So Thiersch wiring, Delorme's procedure and Altimus procedure are procedure done perineally. And for abdominal approach, it is quite difficult and has more complication than the perineal approach. Less recurrence, hence done in young patients. So Ripstein's procedure and Wells procedure are basically done. Ripstein is nothing but mesh placement over the presacral region in order to prevent rectal prolapse in future. Next is a case wherein which of the following does not cause any bilateral HAN. HAN is nothing but hydrohydronephrosis. It is basically obstruction of any urinary pathway leading to dilatation of pelvic calyceal system, which leads to decreased renal function. So in the other three options, it is posterior urethral valve, BPH, and phimosis, which causes obstruction at the bladder outlet region, hence causes bilateral HAN. But in case of PUG obstruction, it is mostly unilateral obstruction, which leads to HAN of the one side. In a patient with critical limb ischemia, the ABPI is likely to be, in this case, the answer is less than 0.4. So it is updated in New Bailey. 0.9 to 1.4 is normal. Less than 0.4 suggests a critical limb ischemia, and more than 1.4 it suggests calcification. So basically, less than 0.9 is a diagnostic of occlusive arterial disease. So it is a quantitative assessment bedside test wherein we take the highest systolic blood pressure of either DPA or PTA or peroneal artery to the systolic blood pressure of brachial artery. So we have seen three questions wherein first question is with regards to image base. Second is we should carefully look in for the not for all of the true, all of the following is true except, and in third scenario it is updates from New Bailey or Sabiston. So we need to get prepared with based on these. So next is a formula kind of question wherein in systemic inflammatory response syndrome, which are the following is true except. So in this case, you need to see the exception here. So basically all are true. Even option B is true, which is the answer, but the term and is not a correct term. It is or. So even examiners can be sadistic like this to give and nor as options. So basically, it is hyper or hypothermia, tachypnea or PaCO2 less than 35, tachycardia and WBC more than 12,000 or less than 4,000. So just look for those or and etc. I would like to add a septic shock, which is nothing but sepsis plus distributive shock. Sepsis is nothing but systemic inflammatory response syndrome with documented infection. And MODS is nothing but two or more organ damage is present along with septic shock. So interleukin 1 and tumor necrosis factor alpha are important mediators for sepsis. So with the distributed shock in mind, the next question is peripheral vascular resistance is decreased in which kind of shock? So basically it is distributed shock because in distributed shock it is of three types: the septic shock, anaphylactic shock, and neurogenic shock. In all the three conditions, the peripheral vessels will get dilated. In septic shock, it is due to bacterial endotoxin. In case of anaphylactic shock, it is histamine release, and in case of neurogenic shock, it is decreased tone to the vessels. So basically, distributive shock causes decreased vascular resistance, which leads to increased cardiac output. So next question is based on which of the following is false regarding rectal CA. Hartmann procedure is done in elderly patient. It is true. Adeno CA is a rare variant. It is obviously false. It is the most common variant. Early morning spurious diarrhea and tenesmus are common. and growth is confined to rectal mucosa in stage of modified Duke staging. So the answer is option B. Altered bowel habits and early morning spurious diarrhea are most common clinical features. Adeno-CA is most common. Um, Here, the question can be from APR and LAR. APR is nothing but abdominal perineal resection, wherein in these cases the CA rectum is present in the lower rectum, which leads to compromising the anal sphincter, and we need a permanent colostomy for these patients. Wherein LAR, we can try to resect upper and middle rectum and anastomose the existing bowel, so that bowel continuity is restored. So in the above three questions, it is mostly related to you reading the question carefully and what kind of shock differences and facts you should know about rectal CA. Next, patient present with slowly progressive tumor for the past 1 year as shown in the image. What is the likely diagnosis? It is Pakka image based question. It is nothing but pleomorphic adenoma. You can see the classical lifting up of ear lobule, and a curtain sign will be positive in this patient. So in usually the facial nerve will not be involved, but during malignancy, due to increased size, facial nerve can be involved. It is a very important topic to be studied. So next, patient presents with dry gangrene as shown in the image. The patient also presents with bilateral rest pain and impotence. Just based on the image, you shouldn't jump and mark as bilateral popliteal artery occlusion or femoral artery occlusion. Rather, you need to also read about the impotence. Impotence is classically seen in Lerish syndrome, wherein it is aortoiliac bifurcation obstruction. So we need to proceed with the iontofemoral graft for these patients. So it is a previous year question. Next question, it is something related to gallbladder. 54-year-old female presents with persistent abdominal pain and bilious vomiting. Patient has had hysterectomy 2 years back. Has nothing to do with the question. On examination, auscultation revealed high-pitched bowel sounds, and investigation shows air within the biliary tree. What is the most likely diagnosis? Gallstone ileus. So, in case in this patient, it is basically to the hysterectomy is basically to divert and put as option B. But the question clearly suggests high pitch bowel sound, which indicates obstruction, and air in the biliary tree, which is nothing but pneumobilia. And the other thing is bilious vomiting, which leads to ectopic gallstone. So hence the options will suggestive of gallstone ileus. It is also the Rigler triad mentioned here. So it is very important for exam. Kindly note it down. Next, according to Glasgow Outcome Scale, what is the score given for persistent vegetative state? So the answer shouldn't jump and mark it as 3, because here they have asked for a Glasgow Outcome Score, not Glasgow Coma Score. This kind of silly mistake should be avoided. So Glasgow Outcome Score is very less likely to be asked because it has already been asked. I just like to point out the common mistake you guys could make. So Glasgow Coma Scale, it is usually tested in exam. So kindly note it down. So the last question, a patient known case of chronic pancreatitis diagnosed with splenic vein thrombosis. Which of the following is not true about this condition? So pancreatitis, I have been seeing questions. Basically, the rank determining questions are from pancreas. So it's better to read in detail. Endoscopy revealed gastric varices, not esophageal varices. So USG abdomen pelvis shows normal liver with an enlarged spleen. Portal vein pressure is normal, and TIPS is done as a part of treatment. So basically, here the patient only has SVT. Nothing has been given with regards to portal vein pressure, etc. So the answer here will be TIPS procedure is not done as a part of treatment, because basic pathophysiology depicted as a peripancreatic inflammation, wherein the inflammation which leads to prothrombotic state in splenic vein due to splenic vein injury. which leads to thrombus formation. This thrombus formation in turn causes gastric varices due to high pressure in the gastrosplenic circulation. Because as shown in this diagram, due to thrombus present in the splenic vein, the tributaries of it will get dilated and causes gastric varices. So the first option is true. So if you look closely, the splenic vein and the superior mesenteric vein joins to form the portal vein. But to be precise, the splenic vein and superior mesenteric vein has a streamlined flow in the portal vein. Hence, the due to difference in pressure, it has a two different air columns inside the portal vein. Hence, this leads to uh, sparing of liver enlargement in this case, and the portal pressure will be normal. Hence, it is known as the left-sidal portal hypertension. Even if you don't know the TIPS abbreviation or what is the thing they are trying to say here, based on these three scenarios, we can come to the answer. If there is a normal liver and the portal vein pressure is normal, means these two options must be true. Hence, we need to go in for the other two options. The tips has been done for increased portal vein pressure or for liver cirrhosis. Hence, the answer will obviously be tips. Even if you don't know anything about chronic pancreatitis or splenic vein thrombosis, we can come to a wild guess with a wild or educated guess just based on reading these questions. Hope you find it useful. For more such videos, kindly like and share and subscribe. Bye.